Welcome everybody. We appreciate all of you, those who are tuned in now on a Monday evening. I know it's hard, especially with most people's day being quite busy the first day out of the week, but we do appreciate your guys' time, and it's going to be a great topic. Before we get started here, I just want to briefly introduce myself. I'm Dr. David Lee. I'm one of the chairs for the Leadership Immersion Track program for PSPS. And I'm going to hand it over briefly here to Dr. Lin to give a brief summary about what the LIT program is all about.
So the LIT program, of course, was started, about 3 years ago, and under the Pacific Pain and Spine and Pain Society. And so this is a 2-year program aimed at developing the next generation of healthcare leaders. It's all about giving healthcare professionals the skills and knowledge they need to make a real impact, whether it's improving patient care, driving innovation, or shape the future of healthcare. So the program offers mentorship, networking, exclusive training, and hands-on leadership experience, all designed to help participants grow their careers and make a difference in the care industry eventually. So it's my great honor, of course, to join this program at the very beginning. Now, actually, make me in a position to contribute back and helping Dr. Lee and many others, and to get a very strong team and network for it.
Yeah, thanks, Alan. And I think your part of this cannot be understated. I was essentially running the program independently by myself, solo last year, and it was extremely difficult. And with Dr. Lin's help, it's been much easier and much more organized. So I appreciate that. As part of the LIT program, we do monthly meetings, and we have guest speakers come on. The idea with these meetings is really to connect the LIT members with different perspectives in terms of the business side of medicine, to learning how to become a key opinion leader within the field, and podium presentations, research, working in academics, etc. So it's a huge variety of different type of topics that we've been doing on a month-to-month basis. Unfortunately, it's not open to the general public, but if you have interest in the next several months, if you attend our annual conference, which we'll have a slide up for registration at the very end of this presentation, you can be a part of this LIT program as well. We certainly are always looking for members to join. And this includes not only fellows, which is, you typically see with a lot of these kind of mentoring leadership programs, but we have also gone as far as including practitioners who have been out of practice for a few years, and also those who are in residency still. And we have some of those who are going to be part of this program tonight. I want to thank, really thank Boston Scientific. They've really helped us out in terms of supporting of the Leadership Immersion Track program. We are going to have a 2-part series of webinars. This is only the first on spinal cord stimulation and some of the proprietary programming and waveforms that Boston Scientific offers. But we have a second one with their new partners, newly acquired partners of Relievant, and they make the basovertebral nerve ablation therapy Intracept. So we'll be doing a second webinar in the upcoming months, so please look out for social media posts on that. The reason that we chose to do this in this timely fashion is that I know it's kind of coming to third, fourth quarter now, and a lot of people have fatigue from webinars and all these different regional and state and nationwide conferences. But I think it's imperative to the education of a lot of the people that are out there, especially ones who are kind of in that leadership immersion track part of their career. And specifically, a lot of the fellows recently just started. Many of the fellows that were in fellowship last year have graduated and are now practicing completely independent on their own. And no such a better time than to make sure that you are well versed in certain types of therapies and mechanisms of action, history, etc., than now. So with that, we're going to kind of move right into our presentation here. And very briefly, before we do that, I'm going to have each of the LIT members, as well as Dr. Trainer, which will give also an introduction on, briefly introduce themselves before we get into it. So first, Dr. Mata.
Good evening. I'm Dr. Robin Mata. I'm a fourth-year resident at the University of Miami in the Department of PM&R.
Dr. Bondal?
All right. Hi, guys. I'm Harjot Vandal. I'm in my third, almost fourth year of practice. Background in anesthesia, then did fellowship in pain, obviously. And I'm in a private practice, single specialty group up in Northern California. And very excited to be here.
Dr. Ho?
Hi, everyone. My name is Dr. Johnson Ho. I recently graduated fellowship at Rutgers Robert Wood Johnson in New Brunswick, New Jersey. My background is in physical medicine and rehabilitation. I'll be joining a new pain startup private practice that's multi-specialty in New Jersey, West Orange.
Great. Dr. Gill?
Hey, I'm Dr. Benjamin Gill. I completed my primary residency in physical medicine and rehabilitation, and then I did a pain fellowship, a pain medicine fellowship at the University of Utah and the Huntsman Cancer Institute. Now I'm in a highly interventional pain medicine group at Omaha Pain.
Dr. Drew, if you don't mind, I'll do your introduction. Dr. Drew is not a limb member. He's been practicing, gosh, as long as I have. So going on, I believe, on his 13th year of practice, maybe a little even longer, but he's a Colorado native who then, kind of similar to my story, left his state to then pursue medical degree. He went backwards. He left kind of Midwest area and came to California, where he did medical school. And subsequently, also PM&R background trained as myself, went to Mayo and did an anesthesia-based fellowship out there as well. Eventually returning back to his native Colorado to now practice, doing both both MSK medicine as well as spine pain management. Drew, I was fortunate to come across within PSPS, but also in other organizations, including Ipsis, where he does a lot of teaching and training as well as research. So we're really happy to have him on. He's been doing spinal cord stimulation for just as long as his career, and has expertise specifically utilizing Boston's algorithm and platform. So we appreciate you. So on that note, we'll move right into the kind of fundamentals of dorsal column spinal cord stimulation, and eventually on to Drew. So.
Okay, good evening. I am Dr. Robin Mata, as mentioned before. I have the pleasure of introducing the foundation of modern day neuromodulation in what's known as gate control theory. So in 1965, Melzack and Wall published a paper in which they theorized a sort of gate control system. Essentially, when painful stimuli comes into the nervous system, it can be modulated by a sensory input from the skin before it's perceived as pain and elicits a response. You can see on the right the original schematic from their publication. It would take years to finally flesh out the details of what the key players actually were. But essentially, a painful stimuli comes into the system. We now know that that's mediated by C and alpha delta fibers and is relayed to the spinal cord and the thalamus and interpreted as pain. But that can close, that gate of pain signal can close by a non-nociceptive input so that that pain signal is perceived less or not at all. And those mediators would be the peripheral alpha beta sensory fibers that in turn activate what we now know are interneurons in the dorsal horn of the spinal cord. And those are responsible for processing and relaying pain information. So it acts at a couple of key areas that Dr. Trainer will go more in depth in later. So really quick video, just kind of illustrating what we all know as a simple concept. You stub your toe or hit your hand, and then you rub that area to diminish your perception of pain. That was actually pretty revolutionary because it opened the door for others to come and test this theory in real life. So in 1967, Wall and Sweet put this to the test by stimulating this in peripheral nerves. But it really was Dr. Norman Shealy and engineers Mortimer and Reswick who took this to the next level. So they actually tried stimulating the dorsal columns of the spinal cord by successfully implanting a subarachnoid electrode in a patient that had terminal cancer pain. It was successful, and the electrode remained intact. If you turn your attention to the right of the screen, this is a cross-section from the original report that was published of the electrode still in place post-mortem. Since 1967, tonic conventional stimulation, or paresthesia-based, also known as low frequency, has been the only stimulation paradigm that was available. That is until 2006. And so the tonic waveform is characterized by a steady sinusoidal waveform with a low frequency, high amplitude, and a moderate pulse width. That constant low frequency stimulation produces a noticeable tingling sensation that we call paresthesia. The dogma has traditionally been place this paresthesia sensation over the patient's specific region of pain to get pain relief. So how do we move along from that original tonic waveform? When we first started out with tonic waveform, we looked at the main parameters of any waveform. So there's the frequency, or how often it occurs, the amplitude, how much energy is being delivered, and the pulse width, or how long is that energy impulse lasting. Those parameters, along with impedance, underlie the total energy that's being delivered to the patient. You can also manipulate those parameters to change the coverage area of that paresthesia and how they perceive that particular sensation. So Yearwood et al. Would come along and they would find that if you increase the pulse width, you could get a greater coverage area of pain, and you could also shift that coverage area lower or caudally. And that was effectively happening because they were recruiting larger numbers of those sensory alpha beta fibers. So you can see in the bottom right, this is from their original paper. If you increase the pulse width from 200 to 600, you get a larger coverage area. And now that coverage area has shifted lower, and more so when you increase to 900. You could also have the same thing happen when you increase the amplitude, because it also increases the number of alpha beta fibers that are recruited. This brought along the concept of a therapeutic window. So a therapeutic window basically says it's a window between when you first start feeling those paresthesias and the maximum level of paresthesia that you can tolerate. So when you're advising on therapeutic window programming, they advise to first determine how much amplitude you needed to coverage that certain pain area, but below discomfort, and then increase the pulse width to widen that area and potentially shift it lower. Since then, it's come a long way. Tonic stimulation, you can see on the left, has had different variations. So you can see high frequency and then burst, which are clusters of stimulation. There's definitely been a lot of change. I'd like to turn it over to my colleague, Dr. Ho, who published a wonderful narrative review on the history of spinal cord stimulation, and we'll be covering the history of tonic spinal cord stimulation studies.
Yeah, hi everyone. So thank you, Robin. Great job. I'll be covering, as she said, the historical tonic spinal cord stimulation studies. So first, this is a figure from a paper that was recently published about 2 weeks ago, covering the visual timeline of spinal cord stimulation technology milestones, describing the evolution of spinal cord stimulation. Robin covered the gate control theory and how stimulation was successfully tested for pain in the 1960s. And in this timeline, we'll see that it marked in red are the hardware development of spinal cord stimulation, where the first commercial SCS system was developed in the 1960s, was first percutaneously implanted epidurally in the 1970s, and the generator became fully implantable in the 1980s with multi-contact leads. In the early 2000s, the batteries became rechargeable. They were MRI conditional since the 2013, and since 2014 and beyond have continued to become gradually miniaturized. Through all this time period, research and modeling from the 1980s through present, and all the modeling and research efforts have informed the software and programming of spinal cord stimulation, which we trace it here, where in the late 1980s, programming became computer assisted. In the 1990s, there were multi-channel and multi-program SCS therapies. In the early 2000s, non-tonic or paresthesia-free was introduced. Closed loop was introduced in the early 2011 area. A lot of expanding waveforms were introduced from 2015 through 2017, and through most recently from 2021 through present, a lot of remote telehealth, AI, and remote monitoring features have been introduced into SCS. So from 1967 through 2006, most of the papers that were studied were all case series. So as we described about Shirley, with the parameters that Robin had discussed, stimulation produced uniform, and they found that in a case series of 10 patients, stimulation produced uniform anesthesia with no decrease in sensation. In the 1970s, North studied dorsal column stimulation with percutaneously implanted electrodes in 31 patients with success. And in the 1990s, Kumar published SCS efficacy in peripheral vascular disease. All of these were mainly case studies, which led to a very pivotal paper in 2005 known as the PROCESS study, which was the first prospective randomized controlled multi-center trial across 12 sites internationally with the goal to establish conclusive evidence to assess the clinical efficacy and cost effectiveness of spinal cord stimulation compared to conservative medical management for the management of patients with failed back surgery syndrome, now known as persistent spinal pain syndrome type 2. And they were looking for patients predominantly with neuropathic leg pain, with a goal to follow up with them at 1, 3, 6, 9, 12, 18, and 24 months. The primary outcome goal was to see if they have greater than 50% pain relief in their legs. And they also looked at secondary outcomes of improvement in back and leg pain, quality of life in the form of the short form 36, function, all improvement in the form of the Osteoarthritis Disability Index, medication usage, satisfaction, and complications. This table is, they had a total of 100 patients that were randomized to these two groups, and describing the patients through primarily patients around 50s. Their last surgery was almost 5 years prior. About half of them had greater than one surgery, and most of them had unilateral leg pain, and the other part had bilateral leg pain, with no significant between group difference in these areas. So the outcome of the primary outcome was that SCS group had 48% of their patients that achieved greater than 50% pain relief, compared to conservative medical management at only 9%, which was found to be a very significant finding at the point of 6 months. The reason why the time frame was at 6 months was because they allowed for a crossover where SCF can go to CMM and CMM can go to SCS, and they recorded that 32 patients chose to go from conservative medical management to SCS. And those patients were followed up to 1 year so that they can also look at the complication rates. And this graph shows that at the mark points of 1 month, 3 months, and 6 months, SCS had about 50% of patients that achieved about 50% relief or more, compared to conservative medical management had maybe up to 10% of patients. Looking at the secondary outcomes, what I've highlighted here are the significant points where SCS showed a significant difference in the areas of leg pain relief, short form, which signifies quality of life, osteoarthritis disability, which signifies function, and patient satisfaction. Looking at their complication, they documented that of 84 patients who received an epidural electrode, about 32% of them had experienced a device-related complication, and they divided that into hardware-related versus biological-related. And the principal complications were related to electrode migration, infections or wound breakdown, and loss of paresthesia. Now I'll share it with Dr. Harjot Bandal.
All right, thank you for that, Johnson. So I'm basically going to talk about some of the novel waveforms that exist today. I'm super excited to talk about this. As Dr. Mata and Dr. Ho kind of mentioned, we know spinal cord stimulation works. It's been working for 40 plus years. But we want to, initially it was this 50-50 club that the PROCESS study kind of showed, where 50% of the people would get 50% benefit. The goal with all these novel waveforms you kind of see here is to basically, now move closer to where we want to be in that 80-80 club, where 80% of the people are getting 80% of the relief. Traditionally, SCS was using this kind of low frequency waveform in the 40 to 60 hertz range to produce that kind of tingling sensation that would mask patients' pain. But in recent years, these new waveforms, as we'll kind of talk about, have really changed the patient experience and the amount of pain relief that patients are getting to really propel SCS to the next level. Now, when Dr. Lee graduated many years ago, he only had to learn about 1 or 2 waveforms, but luckily now we have all these other waveforms that we can use to kind of help our patients. So I'll kind of do a quick speed run through all these waveforms, and then Dr. Gill and Dr. Trainer will really dive deep into the fast waveform. So first off, we'll start off with high frequency stimulation. This was by Nevro. So this is basically looking at 10,000 hertz instead of 40 to 60 hertz. It's a paresthesia-free system. This came out, the Senza study, landmark study published in 2015. And this really revolutionized how we looked at pain studies. This was the largest study at the time with 200 plus patients. It was prospective, randomized controlled study. And essentially, instead of looking at, stimulation, comparing it to conservative medical management, which we know we don't have to do anymore because SCS works, this was looking at comparing high frequency stimulation with traditional SCS. The initial paper was published in 2015 up to 12-month data, which of course showed that HF10, the high frequency stimulation, worked better than traditional SCS therapy. And then eventually they followed up with 24 months data, which kind of showed ongoing benefits. This is kind of hard to see here, but essentially the red line there is the traditional SCS out to 24 months. The blue line is HF10, and you can clearly see SCS works, but HF10 works even better, and the data is good out until 2 years out from the time of implant. So moving forward, we got to talk about burst stimulation next. When you think burst DR with Dr. Ritter, and you think Abbott. So this, as Dr. Mata mentioned, is a change in that tonic stimulation where you basically have these bursts of electrical pulses rather than a continuous waveform. And this is meant to mimic more of the kind of the natural firing of the neuronal cells that are already in the spinal canal. And then the main kind of takeaway from this is that this is meant to maybe work a little bit more on the medial spinal thalamic pathway that also controls the emotional aspects of pain. So the stimulation here is potentially even modifying the patient's psychosocial functioning. And of course, all of our pain patients have some type of depression and all these things that come along with the pain. So this is meant to help even with that. And then the this is paresthesia free. And the next waveform of this is the Flex Burst 360, which is still using that burst DR waveform. With Flex Burst, you can basically do kind of multi-area programming all at once. So you can have a different program for back, different program for leg pain. So it works even better. And then this, kind of the landmark study for this was the Sunburst study published in 2017. So we see kind of a theme here. This is again a prospective multi-center study. With this one, they even added a crossover part to it, so even better study. Initially, it was a non-inferiority study, so it showed that burst was non-inferior to tonic, but it's actually so much better, as you can kind of see in that bottom left picture, that actually showed a superiority to traditional SCS, and patients also had much better satisfaction, less side effects, because it wasn't tonic stimulation, they didn't have the paresthesia. And then quick brief mention, shout out to DRG, even though it's not kind of its own waveform. I think it's separate enough to know about it. This is obviously for CRPS type pain, those really kind of hard to treat pain areas, the pelvic, the groin, the hip, knee, ankle, foot, all those really tough areas to treat. DRG works great for that. And this was shown in the Accurate study published in 2017, which again showed that it's superior to traditional SCS when looking at CRPS type pain. So moving forward here, I think this is kind of the next waveform, not really a waveform, but the next revolution in SCS therapy, which is closed loop stimulation. So you haven't looked at that. I think you really have to look at this. And this is kind of being pioneered by Saluda. So they published their Evoke study. All these previous studies had been 12 months, 24 months. This pushes it out to 36 months, again, multi-center, randomized, crossover. And this one, they also ended double blindedness. So, nobody knew what waveform they were getting. So, really superior study here. And then this is kind of, the ECAP in the bottom right. So you can actually sense what your spine is doing. So you can kind of know what's going on. And then you can kind of control the dose to get even more relief. And then this is kind of what it looks like. I won't get into it because I know I'm running low on time. But if you haven't looked at closed loop, you have to pay attention to it. It's kind of the next revolution in SCS. So moving forward to Medtronic, mentioning closed loop, right? Medtronic's also working on closed loop, but their kind of sweet baby is this DTM, which is differential targeted multiplex stimulation. So essentially what that means is it's using a lot of different electrical pulses that are different from one another to change the frequencies, pulse widths, charge balancing, all that to basically improve pain control. They have their own multi-center prospective RCT out to 12 months, which shows in this graph here that, again, DTM is better than traditional SES. And a shout out to Medtronic and Abbott for having really, really tiny batteries, which patients love. So that's also a plus point to them. Finally, moving forward, we got Biotronic, can't forget about them. So they've got their resonance waveform, which is using this multi-phasic stimulation. So this is essentially a sequence of a bunch of little micropulses with rotating cathodes and electrodes to basically get a deeper penetration into the dorsal column. So you can see in this functional MRI ultrasound imaging, here you have the resonance waveform, which is kind of pushing deeper into the dorsal columns. So you get more recruitment of those cells and also uses less energy. And Biotronic, of course, the only one out right now, which has kind of the daily remote monitoring for all the patients, which they brought over from the cardiac world, so which is great. And again, of course, they have their own study, the Benefit 3 study, which is currently ongoing. They have some patients which have completed the 12-month data, but they're still kind of finishing out that study, but which again shows that it's superior to traditional SES. All right, so that was a quick run through, and then Dr. Gill is going to talk about FAST.
Well, thank you. Dr. Bandal mentioned this concept of the 50-50 club, and then we're moving towards the 80-80 club. Really, the next wave, the next step is 100%, right? We want 100% relief in the right patients, and those that are being identified as the proper candidates for neuromodulation, for spinal cord stimulation. So I'm going to share with you how these novel waveforms continue to advance. But let's, again, do a quick review. So we already heard from all of our colleagues about how in the 1960s, this concept of the gate control theory came out. And that was really the foundation of this neuromodulation principle. Throughout the years, there was more and more publications. In particular, we start seeing these principles of surround inhibition. That was introduced again back in 1967, really, or 1969. Hillman and Wall had talked about this. They'd published about surround inhibition. And you started to see more and more literature associated with that advancing towards this era that we're in now of rapidly progressive novel waveforms. We keep calling them novel, but they're becoming just the current paradigm of what we're being able to treat patients with. So as far as the exact mechanism of this, I really want to hear from Dr. Trainer and his experience, but I do want to highlight some of the research that we have associated with this new approach, with a fast-acting subparesthesia therapy that we can deliver for patients. In particular, let's talk about 4 different studies. These were all published within the past month, presented at the Aspen Miami conference just this last month. This first one was Dr. Anatescu and her crew. It's a prospective multi-center application of fast-acting subperception therapy. In their group of 56 subjects, all of which had on-label indications for dorsal column spinal cord stimulation, the majority, at about 63%, had failed back or persistent spinal pain after surgery, and about 73% had radiculopathy also. At 12-month follow-up, there was statistically and clinically significant improvement in pain and disability, as noted on the slide here in the first and second columns or graphs. But there was also a very high rate of patient satisfaction at 86%, stating that they were much or very much improved in their overall status. And very interestingly, this was achieved with a very short wash-in of just minutes after activation of their initial programming. Similarly, Dr. Birol published a real-world multi-centered study with 86 patients that were also treated with this FAST algorithm, the fast-acting subperception therapy. And this series demonstrated an overall 5-point improvement in pain at 1.6 years, as well as significantly improved disability and quality of life. This study is also continuing with the cohort beyond 2 years, and I'm excited to see how that continues to evolve in this population. Another study this past month that was discussed is Dr. Washaba, and they had similar results in their multi-center observational group. Notably, a significant proportion of these patients scored 2 or less on their pain rating scale, basically saying the pain was essentially gone or absolutely gone, as you can see in this middle graph here. And continuing the trend from these other studies, the overall responder rate is of greater than 50% pain improvement, at least, was in about 90% of patients. Again, pushing closer to that 100% response that we're trying to achieve for our patients. And then lastly, Farrell highlighted the additional benefit of autodose. And so that's another paradigm added to this fast-acting sub-perception therapy algorithm. And as Dr. Trainer will likely describe more, this enhances the patient experience and reduces the need for programming adjustments and ongoing pain improvement. Overall, just from these studies, you can see that there's significant pain and functional improvement with this approach. We've seen this waveform now applied in over 500 published cases with an ongoing excellent outcome profile. I'm excited to see what Dr. Trainer has to say about the mechanism of action and his application in his practice.
Hello, everyone. First of all, thank you for having me. I really appreciate Dr. Lee, Dr. Lin, and the LET members inviting me. I hope you find this portion of the webinar to be very enlightening and informative. So Dr. Gill already presented on the slides, so we'll just go over this very briefly. But Dr. Mata described the gait control theory and the fact that this is really foundational for traditional tonic dorsal column stimulation. And as Dr. Gill also mentioned, in 1969, Hillman and Wall, so it's the same Wall from the Melzack and Wall paper, they published another study incorporating the concept of surround inhibition into the gait control theory. Since the late 1960s, there have been multiple publications on surround inhibition. This is a well-accepted phenomenon in the scientific literature. And then as late as 2012, we have multiple publications looking at surround inhibition and its potential role in the recovery of chronic pain. But up to 2020, nobody really looked at spinal cord stimulation and the potential role of surround inhibition. That was actually until 2022. So Warren Grill, he's a neuroscientist from Duke University. And through his basic science research, he used computational modeling to determine that fast-acting sub-perception therapy, which we're going to go into detail here briefly, was largely working via this concept of surround inhibition. He was also able to tease out the waveform parameters that would fully engage the mechanism of fast-acting sub-perception therapy. So when we look at fast-acting sub-perception therapy, we really need two key elements. The first is precise neural dosing. Precise neural targeting. And really, in order to precisely target the neural structure of interest, you need proprietary technology. And so Boston Scientific has come up with different components that allow them to precisely create a central point of stimulation to optimize fast-acting sub-perception therapy. The first is Illumina 3D. This is a three-dimensional electrical field that allows you to quickly and accurately target the neural tissue of interest. They have this technology called multiple independent current control. And as the name implies, they have the ability to control current on each one of the contacts on the lead. And then the third is the tight spacing leads. So it allows them to move the current in sub-millimeter increments to be very accurate. And then there's also this concept of active recharge. So that's precise neural targeting, are the first key element that we're going to talk about. The second key element is proper neural dosing. Dr. Mata talked a little bit about neural dosing. She talked about the frequency or how fast the impulse is being fired, the pulse width or the duration of a single stimulation, and then the amplitude, so how intense that single stimulation is. So through the work of Dr. Grill, we found that fast-acting sub-perception therapy, in order to fully engage that mechanism, we need to see 30 to 40% of the patient's paresthesia threshold. The pulse width is going to be 210 plus or minus 50 microseconds. The frequency will be 90 hertz. And as Dr. Gill talked about in his last slide, this concept of neural dose automation or fast auto dosing. So again, we need precise neural targeting, we need proper neural dosing, and that's what gives us fast. So Gage presented a poster at NANS in 2023 looking at his trial patients and how quickly they experienced a reduction in their overall pain. And according to his study, patients experienced significant pain in under 2 minutes. If you look at our prospective study, and Dr. Gill mentioned this previously, we found that it took approximately 2.6 seconds for patients to experience a 50% reduction in their pain. And it took 2.6 minutes, 4.2 minutes for patients to experience maximal improvement in pain. And I think that's a really important concept because this is sub-perception therapy. Remember, with traditional sub-perception therapy, we think this acts more directly on the dorsal horn. And there's typically a wash-in period of 48 to 72 hours. So we're now seeing subperception therapy in a matter of minutes, not a matter of days. And so now we're going to go over the mechanism of action in greater detail. And in order for us to do that, I want to orient you guys to this slide because we're going to build off of this. So if you look at the left-hand side, this is a cross-section of the spinal cord. You can see traditional wide space contact leads. You can see the small red circle, which represents the A beta center fibers. And you can see the green circle on the outside, which represents the A beta surround fibers. And so if we look at these wide space contact leads, you can see that shaded yellow circle there is the central point of stimulation. And I would argue that this is a suboptimal central point of stimulation. You can see where we have essentially total activation of the A beta center fibers and partial activation of the A beta surround fibers. Let's see what that looks like in the middle slide here. So if we activate the A beta center fibers, they do have a partial inhibitory effect. They activate the inhibitory interneurons, which downregulate the wide dynamic range neurons and the pain signals at the level of the thalamus and ultimately the primary somatosensory cortex where we perceive pain. But these A beta center fibers also have a partial excitatory effect. So as long as the overall effect is net negative, you're going to see a reduction in the patient's overall pain. And you can see this graphically on the right-hand side here. Now, if we look at the A beta surround fibers, you can see that the A beta surround fibers have a purely inhibitory effect on the wide dynamic range neurons and a more significant reduction in activity at the level of the wide dynamic range neurons, and thereby a further reduction in the patient's pain. So what happens if we look at those two key elements? Remember, the first is precise neural targeting. So if we add those tight space leads, we incorporate multiple independent current control and Illumina 3D, this allows us to be more precise with our central point of stimulation. And we're therefore activating more of those A beta surround fibers, which ultimately leads to a greater activation of the inhibitory interneurons, downregulation of the wide dynamic range neuron. And again, if you look at this graphical representation on the right, a further reduction in the patient's pain. So that's the first key element, is precise neural targeting. Now what happens if we add precise neural targeting plus the proper neural dosing that was determined by Warren Groh? When we do this, we're able to selectively activate the A beta surround fibers without activating those A beta cinefibers that have a partial excitatory effect. And so ultimately that leads to greater inhibition at the level of the wide dynamic range neuron with its projections to the thalamus, the primary somatosensory cortex, and we therefore see a more profound reduction in the patient's overall pain. Again, we can see this graphically on the right-hand side. And so now I'm just going to do a brief case presentation. This is a patient I saw last week. So she's a very sweet 78-year-old lady. She's got an L2 to S1 fusion. This was performed back in 2016. And she had chief complaint primarily of right greater than left low back pain, which was 7 out of 10 on a numeric pain rating scale. This is her sagittal MRI. These are just a few axial cuts here. You can see the level above her fusion. She has perhaps mild to moderate spinal stenosis, maybe a little lateral recess narrowing. But again, this patient was presenting primarily with axial back pain complaints. There was really no lumbar spinal stenosis presentation and no evidence of radicular pain. She did have an EMG that was performed by myself in December of 2023. She had a chronic right L5 radiculopathy. She had no signs of active denervation. This looked like an old radic, and it looked like recovery was complete. And there was no evidence of any other underlying neurologic condition. Prior treatment, she'd had multiple rounds of physical therapy. Most recently was in October of 2023. She had lumbar trigger point injections trying to treat the axial back pain component. She had non-diagnostic response to sacroiliac joint injections. She's had a few epidural steroid injections before seeing me. And she'd even failed a spinal cord stimulated trial in March of 2019 with another company. Her current treatment, she's on pregabalin, 100 milligrams twice daily. She does take Percocet on an as-needed basis. She's using a four-wheeled walker for community ambulation. And she's really only reporting a 30 to 40% relief in her overall pain with the current treatment plan. And again, she had failed most conservative care previously, including a spinal cord stimulator trial in 2019. So we decided to trial her with FAST. Again, her pain was primarily axial in nature. It was right greater than left. These are fluoro images from the trial. You can see the AP image, the most cephalad segment is T7. So you can see we're near the superior end plate of T7. The left lead is approximately midline, and then the right lead is slightly right paramedian. And you can appreciate that as well on the lateral views. You can see where these aren't completely overlapping one another, and that's because of that right paramedian location of that right lead. And so this is her programming. So if you look, we had a central point of stimulation near the top of the T8 vertebral body. On the right-hand side, if you look at her dosing parameters or her neural dosing, her pulse width was 230. Her frequency was 90 hertz. And then her amplitude was 2.1. Remember, we're looking at 30 to 40% of the patient's paresthesia threshold as kind of a baseline. And so this is actually a copy of the text that my rep had sent me 3 days into the trial. So Cheryl's doing amazing, 80% relief, feels so much better. Her daughter's commented on how much more she's standing up straight. She's walking more easily in round 2. She had improvement of her sleep. She was just ecstatic at the relief that she had seen, and she'll be going on to implant. Another patient that I'll very briefly discuss is a patient that I did this morning. She was a 78-year-old lady. She had atrial fibrillation, and she was on Eliquis. And so we did a trial on her this morning, and I'm actually going to do a truncated trial. So I'm only going to do a 3-day trial, which previously I never would have done because most of my patients prefer subperception therapy. And because of that wash-in period, we couldn't do a 3-day trial because we really wouldn't have great data to show that it was or was not effective. But now with this fast-acting subperception therapy, this lady's pre-procedure baseline pain was 9 out of 10. She was a 1 out of 10 when she was leaving the center today. So we'll plan for a lead pull on Thursday that reduces the amount of time she's off of anticoagulation. And we're going to get good data because we're getting almost immediate feedback with regards to the efficacy. And with that, I'm going to open it up to questions and have Dr. Lee and Dr. Lin lead the discussion.
Yeah, thanks, Drew. That was amazing. Again, I want to quickly give a shout out to Boston Scientific for sponsoring this. I think this was quite an amazing overview of spinal cord stimulation, and Dr. Trainer did an amazing job on really explaining fast. I've been to many conferences and have kind of sat in on different discussions, but you know, one of the kind of unique things about this talk is being very open about different mechanisms of action. Fast being one that we haven't heard a lot about, which is, I think, the reason why this webinar is so imperative, is so important. We're going to open up the question and answers. So there's somebody's already using it. That's amazing. We appreciate that. So if you have any questions or answers, you can certainly write them into the Q&A part of your Zoom or the webinar chat. So we'll start off by this. And if you want to specifically target one of the panel members, just make sure that you guys place the name there. So we'll first start off here. So and Drew, I may ask you to kind of curb some of these as they may be a little bit more on the advanced side here. Are there any concerns with insurance payment for repeating SCS, even if different types of stimulation patients who failed SCS in the past? I can kind of answer this too. Drew, please feel free. Alan, I know that you have fundamental knowledge and experience as well. I think there's multiple parts of that question. One, it depends on what insurance it is. Two, I think most importantly, I think it depends on how long it's been since their previous trial or previous implant. So I can tell you, pragmatically that I've done just this. It's not the easiest thing to do, so definitely the exception, not the rule. And it can be difficult to make that case of why you're doing a trial so early on after a trial is done. And really that has a lot to do with like the CPT code is being used as identical. So, from the insurance standpoints, that they're not really necessarily looking at all the granular details of your note and why you're doing what you're doing. So you sometimes are going to have to get on the horn and explain to peer-to-peer exactly what the situation was. But it's possible, but you have to put in a little extra work to be able to do that.
Yeah, so those are all great points, David, and you're very correct. It really depends on, the number of times you've tried a certain therapy and the time between therapies. What I can tell you is in my experience with Medicare in terms of frequency, you really get 2 tries. So, if you try the first time and you fail, generally you're going to be able to try an additional time and then that's it. And so, from a private payer standpoint, you're going to require pre-authorization, right? This isn't going to be anything retroactive. And so documentation is extremely important. And so when you're dictating your note, you really need to explain why you're retrialing the patient, what this new technology is, if there's any data available. I mean, you give as much ammo as you possibly can to yourself to get this approved. It may require a peer-to-peer, but if you've done your homework and you take the time to do a peer-to-peer, I mean, really the carriers are hoping that you don't do that, right? And if you're persistent, oftentimes if you get a peer-to-peer with the right doc, you're going to get that approved. So just advocate for your patients, and we can only hope for the best outcome.
Well, this is great. We got a bunch of questions coming in. Dr. Trainer, I'm going to have you stay on here. So one of the attendees is asking, how's your experience with FAST, treating CRPS, upper limb pain, and where do you place those leads for upper limb pain?
Yeah, so I think FAST works really well in the cervical spine, similar to other waveforms. I think cervical spinal cord stimulation, and that is technically an off-label indication, just so everybody knows, is highly effective. It may be even more effective than, thoracic dorsal column stimulation for back and lower limb. I've had really good success with using FAST for upper extremity CRPS. The good thing about the Boston Scientific leads, remember we need those tight space leads, but they also make 16 contact leads. And so in the cervical spine, that's going to span probably 4, even 5 vertebral bodies. And so it just depends on the patient's pain topography and exactly where we're trying to stem. So if we're looking for, elbow and below, we're looking at C5 and maybe a little bit below. If we're looking at the shoulder or kind of periscapular region, we may have to advance those leads a bit higher. But remember, this is a paresthesia-based program. So in order to engage that mechanism of action, you really do need to paresthesia map these patients. And if you look at our clinical trial as part of our protocol, we had to have at least an 80% paresthesia overlap to consider that as a successful lead placement. And so it's really trial and error. Everybody's wired a little bit differently, but typically with Boston Scientific's technology, it's very easy to quickly paresthesia map these patients.
Dr. Trainer, I wanted to actually add some questions myself, and I think that kind of piggybacks nicely on the answer that you just gave. So when using it in thoracic, because that's the most common, thoracic spine, do you still do anatomical placement for your leads then, or how do you go about designated placements of your leads?
No, I don't actually. If we're looking at low back, I generally will start somewhere near the superior end plate of T7. That's, tends to be the sweet spot for maintaining good back coverage. You can see in our case presentation that our central point of stimulation was at the superior aspect of T8. And that's good because it helps protect against lead migration, right? So if you get a little bit of migration caudally, you're still going to get good stimulation for the patient. If I'm looking at lower extremity pain and specifically foot pain, I'm going to place those leads a lot lower. So today I had another trial this morning, and it was primarily a left foot pain patient. And we placed the leads at the superior end plate of T10 with those 2 16 contact leads spanning all the way down to T12. And at about the disc space between T10 and 11, our central point of stimulation, we lit up her entire leg, even into the bottom of her foot. And so if you're looking at foot pain, we are going to have to implant those leads a little bit lower. And that's also true of diabetic peripheral neuropathy, in my opinion. You really do have to place those leads lower so that we can get good coverage. Again, this is a paresthesia-based platform.
Yeah, and I think that brings up a good point. That's another probably sentinel landmark paper by Dr. Barrelot, where I think this is a little bit lost of an art in neuromodulation, where, a lot of these companies, when they first came out with their treatment or stim paradigms or waveforms, they started relying solely on anatomical placement. For those of you on the call who don't understand that, it's like placing the lead specifically at a place every single time without consideration for actual people's, the patient's symptoms. And you can capture a lot of pain that way with these novel waveforms, but unfortunately, as Dr. Trainer alluded to, you're not being as targeted as you can possibly be. So that's a good point. And one last thing, Dr. Trainer, do you do intraoperative testing, even though you have the tools of FAST and contour mapping? Do you still do intraoperative testing?
Yeah, I typically do it, and I tend to map every single patient. So what I mean by that is I'm mapping the patient during the trial, right, intraoperatively. I actually remap them for the implant. And I think another important thing is before I pull the leads, I always get an x-ray immediately prior to lead removal at the end of their trial. That was also part of our FAST protocol for the Anatescu study, our prospective study. And you would be amazed at how those leads had migrated. I mean, sometimes even a half vertebral body. So where we thought our central point of stimulation was probably very different from where we were actually stimulating. And I think that's important. Again, with the 16 contact leads, you are spanning a fairly significant cephalocaudate direction. But at the same time, I think, in my opinion at least, oftentimes when patients do very well with a trial and then they go into implant and they have no relief, I think we've all seen those patients. It's probably because there was some significant lead migration during the trial that wasn't picked up, and we actually implanted the leads at the wrong location.
Yeah, and I think that answers some of the questions that people were asking about ideal lead placement. I think you really have to kind of look to see which, to your point, Dr. Trainer, which body part or which target you're actually trying to get to, whether it's back versus leg versus distal limb. So, I was told by a mentor colleague of mine is that you want to be a neuromodulator. You don't want to be a proceduralist. You want to really think what you're actually doing and what you're trying to target, as opposed to just trying to mimic, positioning for different types of things, or, placing your leads in an anatomical way without giving much thought to the actual, referral patterns from those specific parts of the dorsal column. So I think that's a great answer. Real quickly, I want to get some of the LIT members involved here too. Dr. Ho had done an extensive review paper, and I highly recommend those of you who haven't read it to make sure you guys check it out. One of the things that I was going to ask him briefly was first credit him for the amount of work that was done to come up with that history of publications that are out there. But Johnson, do you have any recommendations for specific papers that people should read, like if they're getting into neuromodulation for the first time, if they're trying to figure out like what's available now? As Dr. Bandal pointed out, I am very old now, and I was only reading tonic stimulation literature back then. Now there's a huge fund of knowledge out there. So I think it is critical also to kind of cut through the weeds and try to find the best types of papers. So outside of reading your paper, Johnson, do you have any recommendations as to other papers that they should definitely look up or read?
I think especially for people who are in training, residents, or fellows, I would highly recommend the guidelines that are published by the societies as ones to go to. And also ASRA also publishes those anticoagulation tables that we need to know about, very relevant for patient care.
That's great. And then kind of switching gears here, just looking back at the questions. A patient was asking, an attendee was asking about difference between fast and closed loop. I know we kind of skimmed over that very quickly. Fast, again, is kind of a programming paradigm. I know that Dr. Bandal has some experience with closed loop. That's probably putting it lightly. So I'll ask him to kind of chime in on really what closed loop is about and maybe how it differs from a programming paradigm that Boston offers.
Yeah, for sure. I think they're both obviously great, systems with really good data. With closed loop, it's kind of a change in how we do spinal cord stimulation. So as Dr. Mata had mentioned about that therapeutic window. So right now, there's no way for us to kind of measure if we're in the therapeutic window or not. We kind of measure it subjectively with patients. So, you ask the patient, okay, I'm turning up the stimulation. And at some point, they're like, oh, wow, that's too painful. So you reach the top of the therapeutic window. And then you kind of turn it down. And then they're like, okay, I'm feeling it, but it's comfortable now. And then eventually they stop feeling it. So that's the bottom end of the therapeutic window. And then we kind of program the SCS device to kind of stay somewhere in the middle. So, the waveform that you use to stay in the middle, that's, the fast waveform, the DTM, the burst, the Nevro HF10. With closed loop stimulation, you can actually measure the ECAPs that are being kind of being sent the energy to by all these stimulation waveforms and that are being recruited. And with closed loop, you can actually measure when the patient falls out of that therapeutic window. So not just by them telling you, oh, ow, it's hurting, you can actually measure the amount of ECAPs that are being recruited. And if you recruit too many ECAPs, it actually bumps them above that therapeutic window. And then the closed loop system will reduce the amplitude of the current that's being sent out to actually reduce the amplitude of the ECAP. So it'll kind of keep them in that tight window, that therapeutic window. So anytime they turn their head or they take a deep breath in or they stand up, instead of them feeling that jolt or that shock where they'll kind of take out their remote, they'll kind of turn that stimulation down and then probably never turn it back up again because they don't want to be shocked again. With the closed loop systems, the system will kind of detect when patients have that increased recruitment of the dorsal column cells and that higher amplitude of the ECAP, and it'll automatically turn the signal down, and it does it like 40 times a second. So it's like millions of adjustments per day to keep people in that tight therapeutic window.
That's great. I mean, I think that's as about a quick of an introduction to closed loop as you can possibly get. And I know your slides also, I mentioned it in our conversation, but is that what Dr. Vandal was presenting was basically NANS like in like 6 minutes, which is amazing. You'll not get that ever anywhere. So make sure that you guys look up all these different waveforms. I think it's imperative if you're getting neuromodulation, again, to think like a neuromodulator and to do your own research and figure out like what best therapy fits your practice and your knowledge base and your perspective. So one quick last question is, would you say that FAST is a safer option for patients on chronic anticoagulation to minimize thrombus risk? And I'm going to turn this over to Dr. Gill to answer this one.
Yeah, so we heard from Dr. Trainer. He talked about a patient that he has that he's doing a reduced trial. In most situations, you'll see maybe a week-long trial that's being performed. This is an opportunity where you could reduce that even further because you don't have a prolonged wash-in period for this algorithm, right? So it's not going to take 3-4 days to get a response for your patient. I want to point out, in the United States overall, there's this paradigm, and sometimes insurance demands that we do a trial. The whole world doesn't do that. In fact, some of my colleagues I was talking to in the UK, they never trial, right? They just go straight to implant. And this is an opportunity where you could perhaps just right there in the time that you would be doing your trial, doing your paresthesia mapping, capture a response, leave the leads there, and be done. If, again, your payers and whatnot would allow for that. But in any case, again, an opportunity where you could do maybe a 3-day trial if needed for specifically anticoagulation risk, if that was a concern that you had discussed with your patient.
Yeah, and that's the interesting thing of the timing of this is that, I mean, there was actually a recent publication utilizing, ECAP dose control closed loop therapy to basically reduce trials to like within a day. So it's kind of phenomenal how things have come, so far, because even overseas still currently, like in Europe, UK, there's often times where practitioners are doing 2-week-long trials. You understand that if you're just getting into spinal cord stimulation, the risk of that, of course, is, as was discussed, bleeding risk. Unfortunately, I had a case like this not too long ago, where a patient was getting heparinized and on anticoagulation for chronic kidney issues, and we had concerns about that during her actual trial. And so this idea of figuring it out as quickly as possible is, in those situations, extremely important. But also infection, which is also risky things that can even be more daunting, is like dural tears and things of that nature. So the idea here being, of course, is that if we can figure this out quicker, it doesn't necessarily mean that the patient has to rush to make a decision, but then you essentially can get the patient in and out of their trial as quickly as possible, which is also for them a better experience. So I want to kind of conclude here. Alan, do you have anything to say there?
Yeah, so just a very quick opinion. I think Dr. Trainer got the second trial, and he did mention the documentation is very important. So my secret to get the approval from pretty much all the insurance, you have to document why the exact reason the first trial failed, or at least what you believe. And now that it will be the exact question coming from the peer-to-peer review. So they will ask, hey, why do you think the first trial is failed? And then if you can request the record, hopefully the image actually, laryngoscopy actually taken during the trial. So another, information I want to share, of course, Dr. Trainer and then started and in the education committee, and we were trying to have a product showcase this time, right, in the annual meeting. So you will have all these companies have their elbow out, telling you how awesome they are. But for me, honestly, finding how it failed could be as important, or even more important, how it succeeds. Because everybody tell you actually so many successful stories, you will eventually get most of them. But the failure you get from the cases, even small number can define the quality you are going to provide. And then for your long career, for 10, 20, 30, 40, probably for Robin, it will be 50 years a career. You only need 1 or 2 bad cases, right? How to avoid that? And how do you develop the sense, hey, this is the patient I should not touch. And then no way he can benefit from even a child, right? So most of my trials, the immediate question when they return to the office, they pretty much always say, hey, doc, can I keep the trial longer? Can I kind of keep it forever? Because they feel so good. And then, they never experienced something like this before. I think that you are offering a really solid solution, even in the rest of their life. So we should be proud of it.
Yeah, that's great. Actually, that kind of provocative changes, truth be told, is what I look forward to. I think this 50% cutoff is very arbitrary, and it does leave itself, unfortunately, to a lot of placebo effect. So shortening the trial, you have to be cautious about that too. It's like, yes, there are, certain biomarkers and things that we can sense, and we can get a faster subjective response from patients, but we do have to be careful about what we're doing there too. We don't want to undermine the whole purpose of the trial by making things overly efficient. Real quickly here, I just want to let the panel members give any final last thoughts. We're running short on time here. I appreciate everybody staying on the call. Any last final thoughts? Otherwise, we're going to do some housekeeping things just to end here. Great, thank you guys. So I'm gonna ask the panelist members to stay on for just a moment, but real quickly, we do have a webinar tomorrow that's going to be hosted by Dr. O and I, and it's specifically for those who are interested in getting trained on Reactivate. All the attendees for the webinar will be eligible to then being trained and certified on Reactivate implantation at the annual conference, which takes place starts on October 3rd. Thursday. So make sure you guys sign in if you have any interest in getting trained on Reactivate. We already have almost nearly 70 people registered. So obviously we're not gonna be able to choose everybody, but a lot of that will be done. The vetting process will be done after the fact, but in order to be eligible for that, you need to sign on. Next slide. There's 2 APP webinars. So if you're an APP on the call or you have an APP that's interested also in learning about different types of therapies, different from both of our industry partners with Mainstay as well as Abbott. These are QR codes. You can also register on our website. And then in regards to, I alluded to our annual meeting, a couple of things. One, we always want to try to make it as academic of a program as possibly we can. That's only with the help of all of the attendees and you on the call. So if you have an abstract and you want to submit for it, there's a QR code here. There is going to be a winner that's chosen to then have their hotel and the travel subsidized. And so there's a little incentive to do that, but also good to get your name out there to make sure that, if you're part of the academic program, that, that you can get represented at the annual conference, which this year is going to actually be in my backyard of Newport Beach, California. Also, research grant proposals. We do this every single year. Most recently was a neurosurgeon who was awarded this from UC Irvine Neurosurgery Fellowship Program. But you can apply for a grant if you want to do a specific research program or a project. This is a good way to do it, especially for those of you who are trying to get into research and do something relatively small, and then kind of learn from that process. This is a good opportunity to be able to at least get funding for that. and then just registration for our annual conference. We appreciate all of you guys that were on the call. This kind of concludes the actual webinar for spinal cord stimulation. Again, a big shout out to Boston Scientific for making this happen. And we will be back next month with lit members again, talking about basovertebral nerve ablation, the Intracept procedure. Thank you, everybody. Have a good night.